Thank you so much for the great introduction. Really appreciate it. I hope you can hear me well. Something came up at work. I'm actually at the airport presenting from the American Airline Lounge. So hopefully everything will go smoothly. But you know, when my friend Michael Batil invited me, I mean, I take this very seriously. He's done so much for our community and really appreciate all the great work he's done for our NASH patients. And I'm so glad that he also connected with the top-notch hepatologists in Canada, and they're doing a great job with organizing this primary care summit. So my task was to talk about the pathophysiology of MASLD and MASH, and then I'm going to talk about the consequences of the disease. So this is the spectrum of the disease that has been discussed already. And I'm going to take you through the development of steatotic liver disease from MASL, or simple steatosis, and then what leads to progression to MASH, steatohepatitis, and how this leads to progression to fibrosis and eventually liver cirrhosis. It all starts with obesity and the expansion of the adipose tissue. In obesity, there is a state of chronic inflammation, and the adipose tissue is actually infiltrated with macrophages that secrete inflammatory cytokines, and that leads to a state of insulin resistance at the level of the liver, but also the adipose tissue, and importantly also at the level of the muscles. So you develop insulin resistance systemically. And insulin resistance leads to actually the release of free fatty acids from the adipose tissue through the process of lipolysis. And this will actually represent a major source of lipid loading into the liver. There is a second process called de novo lipogenesis, which is basically producing fatty acids from glucose. And that's why being on a high carbohydrate diet can lead to steatotic liver disease. There's also a decreased utilization of free fatty acids in the form of beta oxidation in the mitochondria. And then there are alterations in the secretion of triglycerides from the liver in the form of VLDL. So all these processes will lead to lipid loading into the liver and steatosis. And the two main sources are lipolysis from adipose tissue and a significant upregulation in the process of de novo lipogenesis. In fact, in this slide, you see the process of de novo lipogenesis, or DNL. Glucose through the process of glycolysis is converted into pyruvate, and then pyruvate through several enzymatic reactions is actually converted into fatty acids that can be incorporated into triglycerides. And triglycerides, this is what we see within the hepatocytes in the form of lipid droplets. And in fact, you may hear about this later tonight, but several of these enzymes in the process of de novo lipogenesis can be targeted through pharmacologic treatment. So the first step, as I mentioned, is really the buildup of lipids within the hepatocytes, or steatosis. But then the process of lipotoxicity leads to disease progression to metabolic dysfunction associated with steatohepatitis, or MASH. So the first hit is really lipid loading into the hepatocytes. But then through an increase in saturated fatty acids and other lipotoxic lipid species, this will make the hepatocytes injured, sick. They undergo a process called apoptosis, which is programmed cell death. And that can lead to the activation of the fibrogenic cells in the liver, what we call the hepatic stellate cells. And this is important for our PCP colleagues to understand that collagen fibrosis is actually not produced in the hepatocytes, but rather in the hepatic stellate cells. And these are activated by injured hepatocytes. There is also increase in oxidative stress, activation of the resident macrophages of the liver, we call them Kupffer cells, release of inflammatory cytokines and chemokines that can recruit monocytes and other inflammatory cells into the liver. And these can also activate the hepatic stellate cells. And the end result is really the conversion of these stellate cells into myofibroblasts that can produce collagen and lead to fibrosis. So again, the first hit is steatosis lipid loading. This leads to several parallel hits that can eventually activate the hepatic stellate cells, leading to liver fibrosis. Now, the microbiome plays a role also in disease progression through several hypotheses. We know that the microbiome can extract energy from our diet and convert certain components of the diet that we cannot metabolize as humans into what we call short-chain fatty acids that can be absorbed in the colonic mucosa. So that can increase the amount of calories from a meal. Also, the microbiome can activate the immune system through what we call the toll-like receptors and pathogen-associated molecular patterns, and that can lead to increase in pro-inflammatory cytokines. There is a hypothesis that also the microbiome, the gut microbiota, can produce endogenous alcohols, and these endogenous alcohols can contribute to further damage to the hepatocytes. And finally, we know in animal models that actually feeding mice a choline-deficient diet can lead to severe steatohepatitis. And there's a hypothesis that potentially the gut microbiome can metabolize choline in a way that leads to a state of relative choline deficiency in patients with steatohepatitis that can contribute to further liver damage. Fructose is also known to play a role in the development of MASLD and progression to NASH. We know that fructose can stimulate de novo lipogenesis. It is more steatogenic than glucose. It may lead to increase in intestinal permeability, and that can lead to further inflammation. So really avoiding diets that are high in what we call high fructose corn syrup is important to discuss with our patients with MASLD and NASH. And the muscle also plays a role. We know that this is a bidirectional relationship between the liver and the muscle. We know that patients with advanced liver disease, cirrhosis, end up developing severe sarcopenia, which is muscle loss. Having less muscle mass can actually affect glucose metabolism, and as I mentioned earlier, can lead to a state of insulin resistance. And then the liver itself, through effects on myostatin, potentially through production of ammonia, can lead to a reduction in muscle mass. So basically, having advanced liver disease can affect your muscle mass. Having low muscle mass can affect the development of MASLD and NASH. So to summarize for you, these are the mechanisms of steatosis, lipid loading into the liver. One significant process is increased lipolysis in the adipose tissue and the release of free fatty acids. Another important process is de novo lipogenesis and production of lipids from glucose and carbohydrates. Now we understand that dysbiosis and changes in the gut microbiome can lead to also worsening of MASLD and NASH. There are genetic factors that I will discuss briefly, and then of course dietary factors including dietary fat and fructose. In terms of the development of steatohepatitis and NASH, there is increased activation of Kupffer cells and recruitment of other inflammatory cells into the liver. There is also the conversion of macrophages into a pro-inflammatory phenotype. There's effects on the hepatocyte, lipotoxicity, increased oxidative stress, and the end result is the activation of the hepatic stellate cells and the production of collagen and liver fibrosis. And this is also modified by certain genetic polymorphisms. This is actually a picture of myself without the beard a few years back with Dr. Helen Hobbs from UT Southwestern. And she discovered the first gene and polymorphism that predisposes certain ethnic groups to developing MASLD and NASH. It's called PNPLA3. This was the classic Nature Genetics paper published in 2008, where they did a genome-wide association study, large cohort within the Dallas site study. They had MRI spectroscopy to quantify liver fat. They divided the cohort into those with MASLD and those without significant steatosis, and identified this polymorphism in the PNPLA gene that predisposes patients to MASLD. This is known to be more prevalent in Hispanics and Latinos. That's why they develop more MASLD and NASH. In a subsequent study, Here they explored the interaction between this gene, PNPLA3, and the environment and the BMI. And they showed that if you actually maintain a low BMI, even if you had the variant associated with MASLD, you did not develop steatotic liver disease. Only when the BMI was in the overweight and obese range that this polymorphism can predict higher what we call triglyceride contents within the liver. Another important gene to know about is called HSD, 17 beta 13. This was discovered in another genome-wide association study, collaboration between Regeneron and Geisinger healthcare system. And they actually discovered that a loss of function in this gene can be protective against elevated liver enzymes and the development of MASLD and alcohol-associated liver disease. So we have genes that can lead to progression of the disease and genes that can be protected. There are other genes that I just want to mention quickly, including GCKR, which is involved in de novo lipogenesis, MBOT7, which is important in the incorporation of fatty acids into phospholipids, and then TM6SF2, which is important for the release of triglycerides in the form of VLDL. So in the next few slides, I just want to discuss the disease progression to what we call major adverse liver outcomes, or MALO. MALO in Spanish is bad. So if you have MALO, it means that you're developing ascites, encephalopathy, variceal bleeding, very bad outcomes. And this is from a large study done in Sweden, where they had access to 10,000 liver biopsies done over a 50-year period with very long longitudinal follow-up over 30 years. And they had a general population cohort, so they actually match every patient with MASLD to 5 subjects from the general population without steatotic liver disease. And they showed increased overall mortality in all patients with MASLD, regardless of disease severity. So that's very important to know, that having MASLD, even if you don't have fibrotic MASH, this is still significant and can increase overall mortality. And then they also looked at the severity of MASLD, and they showed a progressive increase in mortality from those with simple steatosis to patients with MASH without fibrosis to those with fibrosis. And then the highest mortality was in patients with cirrhosis. This is a study that was done as part of the NASH Clinical Research Network, sponsored by the NIH, where they had over 1,700 subjects with biopsy-proven disease, so we can determine the stage of fibrosis, followed for an average of 4 years. And they looked at the risk of developing major adverse liver outcomes. And you can see here an exponential increase in the development of ascites, variceal bleeding, encephalopathy, and the increase in MELD score more than 15 in patients with stage 3 and especially stage 4 fibrosis. The yearly event rate in patients with cirrhosis was around 7.5% per year. So this is something I use in my clinic when I see patients with MASH cirrhosis. When they ask me what's going to happen, I say that on a yearly basis, every year you have a 7.5% chance of developing decompensation, which means that we may need to have a transplant conversation. So this is important to provide some prognostic information for your patients. Now, MASH is becoming the most common indication for listing and for receiving liver transplant in the United States. This is from a study that I published with my colleague, Dr. Nuruddin, back in 2018, showing that in the United Network of Organ Sharing Database, MASLD or MASH is the most common indication for transplant in women. You see that in the red line. And then in men, it was only second to alcohol-associated liver disease. Although the majority of patients with MASLD and MASH will die from cardiovascular disease and non-liver cancers, many of them will progress to cirrhosis and they may need liver transplant. And this is becoming the most common indication in the US. Also, patients with MASH cirrhosis are at risk for hepatocellular carcinoma. This is a study from the Cleveland Clinic that looked at a large cohort of patients with established cirrhosis from hepatitis C and MASH, and they showed the incidence rate on a yearly basis. And you can see patients with hepatitis C had a yearly incidence rate of 4% per year, and those with MASH cirrhosis, the incidence rate was at 2.6% per year. And then finally, I want to show this new study that was published in the Lancet Gastro, looking at the impact of type 2 diabetes on outcomes. So this was a large cohort, over 2,000 individuals with and without type 2 diabetes, followed for an average of 7 years. And they looked at the risk of decompensation and the risk of liver cancer. And they showed the clear separation and the increased risk in patients with type 2 diabetes compared to patients with MASLD and without type 2 diabetes. In fact, the hazard ratio for hepatic decompensation was around 1.9 after you adjust for the baseline severity for developing decompensation in patients with type 2 diabetes compared to those without diabetes. And then the hazard ratio for developing HCC was at 5.5. So my take-home message is that steatosis and lipotoxicity are the driving mechanisms of liver injury, inflammation, and liver fibrosis. I want you to remember three cells that play a role in disease progression: the hepatocyte, where you see steatosis, and where lipotoxicity plays a significant role in hepatocyte injury and the development of ballooned hepatocytes. The Kupffer cells, these are the resident macrophages of the liver that play a significant role in liver inflammation and other inflammatory cells being recruited into the liver. And then finally, the hepatic stellate cell, which is the fibrogenic cell of the liver. It is important to understand that genetic polymorphisms are associated with the predisposition to MASLD, but also its progression to MASH and advanced fibrosis. And that MASH cirrhosis has the highest overall mortality and can lead to decompensation and development of liver cancer and the need for liver transplantation. And with this, I would like to conclude and thank the organizers again, and apologies about any noise and the poor quality of my connection, but appreciate the invitation and being part of this great team.